This is part two of the mental health care system and financing mental health care. We were in part one talking about some of the reforms that have been happening in North Carolina since around 2001 and some reforms in 2012 that were specific to crisis intervention types of services are listed on the slide here. So let's go through those. What was noted around this time period was that there was a high level of emergency department usage by people who had mental illnesses, meaning that a lot of folks, their entry point into the mental health care system was not through a counselor's office, but it was through the emergency department. And this is a really expensive way for someone to enter the mental health care system. It usually means that they're in crisis, and so we're not intervening early, but we're actually having to a lot of times respond to a really a sad situation, a dangerous situation, a scary situation. So this is not the point at which we are hoping to get people identified as needing mental health services. It also means that when an emergency department has people who are being treated for mental illness, that there is less space to treat people who are coming through the emergency department for accidents or heart attacks or so on and so forth. So some of the specific numbers were that there was an increase in the number of mental illness emergency department visits in North Carolina from 2010 to 2012 by 17,000. So however many people were using the emergency room as the entry point in 2010, that number went up by 17,000 visits more than what it was in 2010 to 2012, which is a pretty big spike in a short 2-year period of time. This means that in emergency departments, they were noticing more extended wait times. And the wait time in emergency department is called psychiatric boarding. It's not supposed to exceed 4 hours. So the way you can interpret that is if I come into an emergency department for a mental illness issue, I'm supposed to have been triaged or determined what should be the next course of treatment for me within 4 hours. But in North Carolina around this time period, they were finding that the average was about 3 days at a state operated facility at a cost of more than $7 million. So we really want to reduce that wait time, but it can be difficult, especially in hospitals in rural areas, to accommodate the folks who are coming in through the emergency department. Another issue is that there's a 27% repeat rate in 2012 for people who are using the emergency department for mental illness. So you use it once, and within 30 days, there's a 30% chance that that same person will come back again, and an overall 27% repeat rate. Around 2012, also finding that mental illness crises were resulting in a lot of things showing up in jails and prisons in North Carolina, and that is also another very expensive and costly way for people to enter into mental health care treatment. So some of the solutions that were proposed to deal with this were walk-in crisis centers, youth mental health first aid training, training EMS staff training, so getting people who drive ambulances and are paramedics to be trained with mental illness response, developing person-centered crisis prevention plans, so working with people who are already in the mental health care system and actually coming up with ideas for if a crisis should occur, this is the way that we're going to manage it, doing more care coordination, and then doing more telepsychiatry. If you want to click on the link here, you can learn a little bit more about telepsychiatry in North Carolina. So now this brings us to 2015, and what's happening in 2015 is that Governor McCrory has appointed a 24-member interdisciplinary task force focused on mental health and substance use. And this task force is charged with finding ways to spread existing best practices around to different providers and also exploring the options and the success and ways to improve mental health and substance use courts, which would keep people out of jails and prisons and get them treated for mental illness instead. Reducing stigma around access to care and treatment for mental illness, looking at the criminal justice system and young people with mental illness and their needs in particular as being distinct from the adult populations, and then finally looking at how the mental health care system links with those who are in the foster care system. So this task force will meet over the course of 2015, and then the spring of 2016 will bring some recommendations to the governor. The governor will present those will work with the legislature to determine what will actually get implemented. So there's likely to still continue to be some reform on the horizon for North Carolina. Now, when you think about being a counselor within the mental health care system and knowing that you are part of an interdisciplinary treatment team, you think about, well, what is it that counseling adds to the mental health care system? And what I think that we add is that we aren't just focused on trying to come up with somebody's diagnosis or looking for the root causes of their problems, but what we are really good at doing is making an effort to help people to cope with the symptoms that they're experiencing in the present moment. We're also focused on wellness and trying to get people to have an improved quality of life overall so that they can live in the community, so they can work in the community, and they can receive their treatment in the community. And some things that are helpful and hopeful are that we know that as the governor's task force has been charged with looking at stigma, we know that while stigma still exists, the rates of stigma against mental illness will decrease with education and exposure. So if we can get people talking about mental illness, the more we can talk about it, the more we can bring it to light, the more we can talk about different types of treatment options, the more we can combat stigma. So that's a good thing. It actually works. Here are some 10 pillars of state mental health overall. I'm not going to go through these. You can pause and read more about here. Pretty common sense, though. This is an interesting map here that shows states where the amount of dollars that the state spent on mental health in their budget from fiscal year 2014 to fiscal year 2015 either increased, decreased, or stayed about the same. And you can look on here and see that North Carolina has actually decreased in the amount of state spending that they are putting dollars towards. And so if you read the little box in here, to the extent possible, budget status is based on non-Medicaid state general fund dollars allocated to inpatient and outpatient mental health care for children, youth, and adults. And so in North Carolina, that there has been a decline. Now, the sources of mental health care funding a lot comes from Medicaid. That's why it's bolded on your slide here. Medicaid is going to be a big ongoing source of how people pay for mental health care. Medicare, which is for people with specific disabilities and older populations, is also another source. There are block grants that come from the federal government to states to provide certain types of services. And then there are some specific state funds and county funds, but that are available too. Of course, there are private sources like different insurance payers, charitable sources, philanthropic organizations, and then of course those clients of counseling services that just pay out of pocket. When you think about all these different possible sources of funding for mental health care, you want to think about what the role of that funding source is and the influence that they have on the overall way that services are delivered. So certainly people who are spending a lot of money on mental health care, or organizations that are spending a lot of money on mental health care, are going to have some stipulations about how that money gets spent. Bringing up stigma again, it's important to note that there has been a discrepancy in the amount of proportion of funding that goes to mental health or behavioral health care versus the amount of funding that goes to medical, physical, physiological health care. And part of why there is such a discrepancy in those proportions is because of stigma. And so it is the shame associated with mental illness and the lack of talking about it, and that keeps that being able to play out in our system year after year after year. And if you remember to first um, the first part of this video series, and we talked about how in the 17 and 1800s in the United States and in colonial America, there was a lot of illiteracy, and so people, and that was keeping change from occurring. And now, while illiteracy might not be the main problem, but just continued stigma and lack of talking about it. So we really want to shine a light on talking about mental health and mental illness so that there is adequate funding put towards mental health care just as there is towards physical health care. This chart here shows how Medicaid is expected to finance a large and growing share of mental health treatment spending. Medicaid represents the blue portion of this graph in each of these bar graphs, and you can see in 1986 Medicaid was about 17% of overall spending, and that number has grown to 2014 it was at 29%, and in 2020 is expected to represent about 30% of all mental health treatment will be paid for through Medicaid. So it'll be really important that counselors continue to advocate to be paid well by Medicaid, to get reimbursed well by Medicaid. You can see that some of the other sources of funding would be out of pocket, which has actually gone down from about 18% up to 10%. And part of that is because private insurance has gone up. So fewer people need to pay out of pocket, because private insurance would be the next color here, the red, and that's gone from 20 to projected up to 25% of overall. All right, the next slide here shows a, let's move that up so you can see better. The prescription and drug and hospital spending is expected to be a smaller share of mental health treatment spending in 2020. So that's, again, that least restrictive environment, and the Olmstead decision from 1999 is sending more people out into the community, and so that's going down. You can see from 1986 to 2020 to 2009 that retail prescription drug spending was about 8%, and then it went up to 28%. And this represents really the increased proliferation in the amount of psychotropic medications that were available, the rise of Prozac and Paxil and Zoloft and so forth coming from 1986 to 2009, and then that number going down a little bit, or predicted to go down a little bit, from 28% to 26% in 2020. And part of that is because of the patents for those original psychotropic medications is going down, and so the price of prescription drugs is predicted to go down a little bit more. You can pause the recording here and take a look at this for yourself and see what some of the predictions for 2020 are likely to be. But overall, we know that money is a major issue for the mental health care system and will continue to be for a long time. So it's really important that as a counselor, not only do you learn about how to do really good work with your clients, but it's really important for you to understand how the system works so that you can advocate for yourself. You as a counselor are a really important part of the mental health care system, and you need to be a savvy part of that system so that you can advocate for getting paid well, because you're holding up a big piece of the system by providing those outpatient mental health counseling services.